The first step in robotic spine surgery is to verify that the robotic arm is functioning as intended. This automated process is performed by the robotic system itself. During the arm setup, the system conducts an auto check by moving through the maximum range of motion at all its joints. Finally, the system performs compound movements and prompts the user to verify the accuracy, ensuring the arm is ready for precise operation during surgery. The accuracy verification tool is then inserted through the arm guide, ensuring it enters the divot without making contact with the sides. The system requires a manual confirmation of accuracy from the user. Once this step is completed, the accuracy check is finalized, confirming the system is ready for precise operation. The robot is then mounted on the table and the surgical field is scrubbed, painted and draped. Conventionally, one set of drapes is placed on the patient's first, followed by the draping of the robot. This approach ensures that the robot remains sterile throughout the procedure. Additionally, a separate sterile sheet is used to cover the lower body of the patient, maintaining sterility in the surgical field. If the robot has been used in another operating room and the surgical field is already draped, sterility is maintained by draping the robot while it is in the launched position, without mounting it on the table. This ensures the surgical environment remains sterile during the procedure. The robotic system requires that the patient remain as immobile as possible while drilling and tapping trajectories in the spine. To achieve this, the patient's anatomy is connected to the robotic arm using a mount coupler or a bridge. Various methods are available to secure the patient's anatomy, and one such method is the use of spinous process clamps. The accompanying photo illustrates the spinous process clamps and their components. Here, we can see the robot mounted on the operating table with the arm stretched and connected to the patient's bony anatomy utilizing the spinous process clamp. The clamp is attached to the base of the spinous process and can be used in cases from T1 to S2. However, we found it to be bulky, obstructive to the surgical field, unsteady, and cumbersome, which led us to discontinue its use in our practice. The shanks pin is a versatile tool for patient mounting and is commonly used in lumbar fusion procedures. The iliac crest is considered a safe and reliable site for placing the shanks pin due to its wide margin of safety. In cases where instrumentation is planned at more cranial levels, experienced surgeons may opt to place the shanks pin in the pedicle under fluoroscopic guidance, ensuring accurate positioning and stability. When placed in the posterior superior iliac spine size, the shanks pin enables instrumentation from S2 up to L1 in minimally invasive surgery and up to L2 in open surgery. This limitation in open surgery arises because extensive paraspinal muscle stripping increases intervertebral movement, making the anatomical structure less stable and unreliable for precise instrumentation. When placing the shanks pin in the posterior superior iliac spine size, caution is necessary as it may occasionally obstruct the trajectory of the S2LR iliac screw. In such cases, the screw should be placed last, with minimal patient movement to maintain accuracy and safety. Additionally, all surgeons and operating room technicians working with the robotic system must be familiar with the location and operation of the emergency stop buttons, both on the robotic arm and the workstation. Clear and closed-loop communication between the OT technician and the surgeon is essential to avoid accidentally moving the robotic arm while instruments are still within the arm guide, ensuring a safe and controlled surgical environment. The shanks pin can be placed at vertebral level immediately below the lower instrumented vertebra when cranial thoracic levels of instrumentation are required. In our initial cases of thoracic instrumentation, we utilized the shanks pin in the pedicle, which provided adequate stability and support for these procedures. With increased experience, we observed that in patients undergoing kyphoplasty, the robotic system could successfully execute trajectories without being physically mounted to the patient. Building on this success, we replicated this approach in the cervical and thoracic spine by utilizing power tools and applying minimal force on the robotic arm during instrumentation. Additionally, we take care to avoid any movement of the patient, ensuring precision and maintaining the accuracy of the robotic system. The robotic arm is positioned into its full stretch, and depending on the upper instrumented vertebra, the shoulder is adjusted for optimal alignment. If additional adjustments are necessary, the robot can be moved cranially or caudally to fine-tune its positioning, ensuring precise instrument placement throughout the procedure. After physically mounting the robot, the software mounting is completed by pressing a button on the workstation. This action locks all further manual movement of the shoulder, making it crucial to ensure that the cranial-most trajectory can be achieved before locking the position. This step ensures that the robot remains accurately positioned for the procedure without any unintended adjustments. The robotic arm is equipped with 2 infrared cameras and 1 optical camera, which are used to detect any obstacles it may encounter while moving through the surgical field. The process of mapping the topography is referred to as the 3-defined scan. Additionally, the work volume can be manually adjusted using the edit function, allowing for further customization of the robotic arm's movement and workspace. The robotic arm swings in an arc of 180 degrees, scanning the surgical field for any potential obstacles. During this scan, overhead lights are turned off, and reflective surfaces, such as the metal bridge, are covered to prevent interference with the scan. Collision detection is employed to establish the no-fly zones for the robotic arm, ensuring it avoids areas where obstacles may be present. If the surgeon's or nurse's hand is inadvertently scanned, it can have cascading downstream effects, preventing the arm from reaching the required trajectory. During the scan, the nursing staff verifies the navigated instruments by placing their tips into the divot in the robot reference array. In long segment fusions, a repeat 3-defined scan is necessary when moving to the next segment to ensure continued accuracy and safety. Errors in the 3-defined scan can also occur if the camera clip of the drape is not placed properly. To avoid such issues, it is crucial to pay attention to every step of the surgery, ensuring that all components, including the camera clip, are correctly positioned. This careful attention helps maintain the accuracy of the scan and ensures smooth operation of the robotic system throughout the procedure. The process of registering the robot to the navigation system is known as snapshot acquisition. In this process, the robotic arm moves to a predefined position, and the snapshot tracker with glands is used to determine the arm's position at all times in relation to the navigation reference frame. Common issues during snapshot acquisition include the tracker failing to be identified due to improper placement of the glands, blood tinging, or the glands being obscured from the navigation camera. These problems can hinder accurate tracking and may require corrective measures to ensure proper registration. In the event of a loss of navigation accuracy, the system provides an option for a navigation accuracy check. In the current example, the blunt passive planar probe is placed on the spinous process, but the navigation screen does not reflect this correctly. This indicates a need for resnapshotting to restore accurate registration and ensure proper alignment of the navigation system with the surgical field. During navigation, at least 3 passive marker spheres must be visualized to ensure accurate tracking. After repeating the snapshot, the return of accuracy can be verified by placing the blunt passive planar probe in the divot. It can also be confirmed by placing the probe on known bony landmarks. If accuracy is still off, repeating the scans is necessary to achieve optimal precision and ensure reliable navigation during the procedure. The fiducial array used during intraoperative CT acquisition consists of 4 metal beads, while the array used in CT fluoroscopy contains 52 beads. The robot determines the location of each vertebra in space by identifying the fiducial array in the acquired images. This allows for precise mapping and alignment of the vertebrae during the surgical procedure, ensuring accurate navigation and instrumentation. The fiducial array is attached to the robotic arm using an extender. The robot arm must be positioned appropriately to ensure that the target vertebrae and the array are sufficiently visualized. In the CT fluoroscopy workflow, this involves drawing a spine line by selecting a head point and a foot point, then labeling a vertebra in between. If the spine line is drawn too short or too long, it will need to be redrawn to ensure accurate visualization and alignment of the vertebrae for navigation. AP anterior, posterior, and lateral radiographs of the target vertebrae, along with the fiducial array, are acquired after fine-tuning the robot arm position. These images are essential for verifying the alignment of the vertebrae and the fiducial array, ensuring accurate navigation and planning for the surgical procedure. Once the images are acquired and their adequacy is verified by the system, the fiducial array, along with the extender, is removed. The robotic arm is then moved to the oblique position to continue with the procedure, ensuring that the arm is optimally positioned for accurate instrumentation and navigation. The oblique image is acquired with the C-arm positioned at a 65-degree lateral angle. The fiducial array is adjusted to ensure both the array and the target vertebrae are adequately visualized. Once these adjustments are made, the CT fluoro verification is performed to confirm accurate alignment and positioning before proceeding with the surgical procedure. In the scan and plan workflow, a single point at the center of the target vertebrae is marked using the blunt passive planar probe. The robotic arm is then positioned so that the star marker of the fiducial array centers on the area marked by the blunt passive planar probe. This step ensures precise alignment between the robotic system and the target vertebrae for accurate navigation and instrument placement during the procedure. The fiducial array needs to be lowered as close to the patient anatomy as possible. Fine adjustments are then made to the robotic arm to position the star marker as close to the patient's anatomy as possible, without making contact. This technique ensures that more vertebrae are included in a single scan, improving the accuracy and efficiency of the imaging and navigation process during the procedure. After placing all the screws and verifying their position via fluoroscopy, returning to the home page unlocks the free movement of the robotic arm. The robot is then placed in the storage state, and the positioner is manually locked into position. The manipulator is then reconnected to the robot, and the system is unmounted from the bed frame adapter, completing the procedure and ensuring the system is properly stored for future use.